With that, I want to introduce Dr. Rebecca Kumar. Dr. Kumar is an infectious disease physician at MedStar Georgetown University Hospital. She completed both medical school and internal medicine residency at Georgetown and then went to Northwestern for infectious diseases fellowship. She also did an advanced training year as part of an NIH-funded T32. She has a specific area of clinical and research interest in immunocompromised patients, specifically transplant recipients. Dr. Kumar, we really appreciate you joining us. Next is Dr. Lauren Wiesner. Lauren is a graduate of our program. She's also one of the associate chairs of emergency medicine at Washington Hospital Center, and she's had the role of director of emergency preparedness in the department for the last 10 years. She's helped with the Ebola outbreak preparedness for COVID and now monkeypox. Last, Dr. Kate Kellogg, the Assistant Vice President for Quality and Safety for MedStar Health. She oversees system-wide patient safety as well as ambulatory quality. She serves as the systems executive lead for COVID infection prevention response and leads system-wide infection prevention. She's an assistant professor of emergency medicine at Georgetown and practices emergency medicine at Washington Hospital Center. Again, thank you all for joining. I'm really looking forward to the conversation. I wanted to just start us off. Dr. Kumar, if you could just give us an overview. What is monkeypox?
Yeah, thank you so much for having me. So monkeypox is a virus that was initially discovered back in the 1950s when there was an outbreak of illness amongst a group of monkeys. And so since then, we've learned more about this virus. It's a member of the orthopox virus family, which includes things like the virus that causes smallpox and the virus that causes cowpox. This is important because if you have antibodies to one of the orthopox viruses, it's generally thought that you are protected against the other orthopox virus family viruses. It's seen as being endemic within Western and Central Africa, but right now we're experiencing a global outbreak, which involves all continents throughout the world.
Great. And I think I heard you say normally, it has been thought to be in Western and Central Africa, but now we're seeing a worldwide pandemic. I'm wondering if you can speak to how historically we've thought about it's being contracted and then maybe what's changed.
Yeah, so typically the way that we say that it is contracted is through either direct contact with an animal or with a person who is infected with monkeypox, and essentially either like skin to skin, but essentially any sort of like lesion contact. The other concern, or the other way that it can be contracted, is through infected fomites or infected particles. So like from skin flakes, etc., that may be on blankets or on the ground that get re-aerosolized. There is a concern that it can be transmitted that way. And also through respiratory means as well, which is why we recommend not performing any sort of aerosolizing generating procedures, aerosol generating procedures.
Okay, great. And so I'm curious, has that changed? Do you think that how it's transmitted, do you think that that's changed? And is that part of the reason we're seeing this global outbreak?
Not as far as I'm aware. Currently, the global outbreak that we're seeing right now is more related to skin-to-skin contact through sexual contact and close contact. And so the way that it currently came about to attention was in the UK initially through people who had the sort of atypical presentation where the lesions were found mostly in the genital or anal region.
Okay, great. Could you talk briefly about the mortality associated with this and the epidemiology associated with it?
Right. So currently, in this current outbreak, we haven't had any issues with mortality right now. The concern is mostly with our immunocompromised patients, that they are at higher risk for complications related to the disease and to death related to the disease. The highest number of cases that we've seen globally right now has been in the UK, but this is also where it was initially identified outside of the West and Central Africa. Within the US, we've currently had 142 cases identified by the CDC, which was last updated yesterday at around 2 p.m. And this includes 2 cases in Maryland, 1 case in Virginia, and 4 in the DC area.
Okay. And do we know if any of those are MedStar cases?
As in within our region specifically?
Any 4 cases?
Yes, we do know that there's been a case close by. I'm not sure how much I can say with PHI stuff, but.
Okay. All right. Great. And so I think I heard you say 4 cases in DC. Anything else, and Rebecca or Lauren or Kate, anything else that can be shared about those cases that would be relevant to this audience?
I think regionally, we've seen some travel-related cases and some not. So considering the whole DMV region. So some of those trace back to travel, but then at least 1 or 2 not. So of course, that makes us more concerned for potential community spread. And so that is certainly, I think, raises all of our alarm bells a little bit when we have cases that are not travel related. And we do know that that has happened regionally.
Yeah. And so, right, I think that a big piece to that is how it's transmitted and if it's just direct contact or not. Kate, would you say, and to all the panelists, would you say that there's a concern that there is transmission that's not just direct contact?
No, actually, I think direct contact and actually it's more prolonged contact even. So, right now, particularly with the strains of COVID that we're dealing with, it's quite contagious, right? So we're seeing people that have relatively short periods of unmasked contact with one another seeing transmission, right? So I think we all have kind of that raised, our hackles are a little bit raised from all of our COVID experience, particularly right now, through all of our contact tracing experience and all of that. But monkeypox, it's a much longer period of contact. It's really 3 hours of unmasked shared air, and then the direct contact, of course. And Dr. Kumar mentioned fomites, and particularly around skin flakes and such. So that's really, shared bedding. It's intimate contact. So really just thinking about that, particularly as we worry about, any risk we might have or bringing home to our families or that sort of thing. It's intimate contact. But certainly we know in the community, we have plenty of folks having all sorts of intimate contact with one another. So I don't think we're concerned about any change in that transmission, Munish. That's just the mode of transmission, and it certainly happens in the community.
Yeah. Okay. That's great. Lauren, I want to pivot to you in just a moment about the typical presentation, but Kate, to get back to what you were saying with the intimate contact, how does that relate then? There's 2 aspects for all of us, right? One of it is we want to diagnose it when it comes through the doors. The other is we want to protect ourselves. And from the intimate contact perspective, how are we as clinicians at risk?
Well, this is when I go on my PPE soapbox, Munish. Thank you for giving me the opportunity to wax poetic about the importance of PPE. Do you mind if I share a slide, Munish? Is that okay?
Yeah, please.
Let me just, because I have this kind of summarized here. I think just we can kind of look at it as we talk about it. Can you see that slide with IP on it? Okay, great. So we talked about transmission, close contact, respiratory droplets. There's this theoretical risk for airborne. CDC is talking about pulling that back. Again, feels familiar to some of the 2020 discussions we all had. But right now, there's this theoretical airborne, but really very unlikely, it seems. And then rarely from the fomites. So source control is, again, very important. And I know we're all having kind of like, Ashton Kutcher's going to pop up because we're getting punked that we're doing this again. But we really are. A lot of the same messages that we've been saying for 2.5 years, masking all of our patients all the time. And then for source control here, if you have a patient who does have these lesions, and I know Lauren was going to talk more about the presentation with the rash, but actually covering those lesions. So if you can put a sheet over the patient's lesions, that can help with source control. Now, PPE. Again, this is the most important thing that we have. This is our best device for protection of everyone. And another good thing about the silver lining from COVID is that we're all quite used to this PPE. It's the exact same PPE that we used for COVID: gown, gloves, N95, and eye protection. So the thing about this is anytime you have a patient that's febrile with a rash that you think even possibly might be monkeypox, just put on the PPE. I know it's a total pain, but also the contact tracing and monitoring that we need to do if we do have a positive patient is extensive, and you don't want to be stuck in that loop. It is much easier in the long run and safer for everyone to just put on the PPE. So if you're questioning it in your mind, it's one of those, like, if you think about it for 10 seconds, you've thought about it too long, just put it on. And so those are our 4 key PPE pieces, and that totally protects us from both those respiratory droplets, even if there was any airborne component, and then the contact. So that PPE will protect us. For patient placement, just since we're here talking about it, put these patients when we can, single patient room. This was mostly in ambulatory, but I know we can only do so much. We're in our environment, but when we can, and airborne and contact precautions, that's kind of that PPE piece. We don't need to have negative pressure if we can't do it, right? If you can and it's available and we can make it happen, great. But we don't need to go crazy over it. If it's available, we use it. And then just keep the door closed, which again, I know is also hard. In our departments, I'm always closing the door, particularly with the PUI patients, keep the doors closed. But just reminding everyone about that too. So those are kind of the key IP points. But if there's one thing, I don't know what the other people that are on the panel feel, but for me, there's one thing you take with you today. And please, when you're doing your huddles at the beginning of your shifts, when you're talking with the nursing staff and your residents, if there's one thing you can ask them to remember, it's please just put on the PPE. And that is the number one thing, because it's so simple and it's so protective. So that's my big push, Munish.
Okay. Yeah. Message received. Great. So Lauren, I'm wondering if we can talk a little bit about the typical presentation. What should we be looking for if we're suspecting this when patients present to the ED?
Right. So first off, the incubation period for this disease has a pretty broad range. It's 5 to 21 days, though most patients will start having symptoms within a week or 2 weeks. So that's kind of the range you're looking at from after an exposure. And initially, they'll have kind of viral prodrome type symptoms. So fever, of course, headache, body aches, back pain, chills, just profound fatigue. And oftentimes they'll have lymphadenopathy before they truly develop the rash. So that's kind of the hallmark initial symptoms. And then, of course, there's the rash. And I'm going to share my screen just to show you this picture, because I think a picture is worth 1,000 words. Let's see if I can do this. All right. Can you see the picture?
Yes.
Okay, great. So on the right-hand side, you can see the small 6 little pictures show the evolution of these vesicles. So they start out pretty small, a little bit of vesicle after just having kind of a flat red little bump, and then become in a pustule. Then they become more umbilicated, as you can see in the third picture, and that eventually will start to crust and ulcerate, and then that crusting and scab will fall off, and eventually the skin will heal over from that point. And you can see there's a little bit of a red base around the lesion, but it's not a large area of redness surrounding the lesions. I like the pictures on the left because you get a little bit of a close-up, and you can see that you'll have lesions in varying stages. There's on the top picture a couple that look umbilicated at the top and bottom, and one that even shows like a little bit of crusting happening, but then smaller lesions that are really almost in that vesicle stage. And these can occur really anywhere on the body. It's most common that they'll start on the face and then spread more peripherally, but as was mentioned already, there have been some cases where it's a little bit more atypical, where there are genital or anal lesions as the primary site that you'll see the rash. It can be a painful rash. The big lookalikes for this type of rash are things like chickenpox, herpes zoster, Coxsackie virus, so hand, foot, and mouth, and secondary syphilis. So if you're kind of thinking about those illnesses as a potential that your patient has, then monkeypox might also be on your differential and something to consider. So that's really the big hallmark, is the rash. Unlike a lot of other viral illnesses, this one at least has this, which we can kind of go off of recognizing that rash. So I'll unshare the screen now so you don't all have to stare at that unpleasant rash. But that's the main way that these tend to present.
Okay, great. And would you say that with the differential diagnosis that you share there, would zoster, if you're worried about that, like, would you ever see it focally like that, or is it present generalized?
Yeah, so I think if zoster is on your list as a potential, that is a mimicking type rash. Of course, if you have a rash that looks very dermatomal and they don't have any other of the epidemiologic links, you may be favoring zoster. I don't think every zoster case has to be tested for monkeypox, but if there's any sort of concern, it doesn't have to be disseminated when you first see them. They may be in the early stages where you're just seeing a few lesions, and it's more subtle than some of the pictures that get spread around.
And Munish, I'll just add to what Lauren said. I totally agree. And, we've been assisting the urgent care with discussing a lot of their potential cases with Department of Health, which has been helpful to think through kind of when they want to test and when they don't. We have seen a couple of cases of zoster that are clearly dermatomal in a patient that does not have, as Lauren said, any known exposures or travel and that sort of thing. And they've declined to test those. So definitely a good discussion, important to think about, but probably less likely, as Lauren was saying.
So I guess that brings us right into who should we be testing. I can talk a little bit about those criteria. So the CDC, their criteria for a suspect case is a new characteristic rash, or someone who meets one of the epidemiologic criteria and you have a high clinical suspicion for monkeypox. So that's pretty broad. There's a lot of ors in that because if they have a risk factor, it's something you want to consider. So I'll go through some of those epidemiologic criteria. But I think Glenn Wortman's words of advice on when to consider testing is he said that if you have a disseminated vesicular rash, but no epi criteria, we should still treat as a monkeypox rule out. However, if someone has a nothing burger rash and no epi criteria, they should not be a concern. So, not every rash needs to be tested. Consider it in your differential, but you can kind of focus on the ones that look more characteristic to what we're describing. So the epi criteria, what are they? So there's travel within 21 days, because that's that incubation period, to an area with confirmed cases of monkeypox. Now that's become very broad, and CDC has this great global map. If you just Google CDC monkeypox global map, it'll show you where all the cases are and what countries are currently impacted. I think right now we're up to 41 countries, so it's not one that we can really easily list off. So you want to check in real time. Of course, there's the endemic West African and Central African countries that are always on that list as well. And we now, of course, have local cases too, so that muddies the water on the travel question. But if someone has traveled, that does present as a potential risk factor. Then there's Yep.
If I might ask that question, is that question still relevant? Or I guess it's just a matter of pretest probability. If somebody's coming back from West Africa, maybe your pretest probability is high, but we're all in DC. And if there's cases here, does that mean that everybody checks that box?
That's a good question. I think adding any sort of data to your decision is helpful. Certainly, if we become having more and more cases in our area, it becomes less and less relevant. But I do think travel at this point is still useful, especially to areas where there are many more cases, like the UK. That would raise a little bit a higher red flag, I think. So next criteria would be contact with a person with a similar appearing rash or who has received a diagnosis of confirmed or possible monkeypox. That feels pretty obvious. And then close contact with individuals within a social network that's experiencing monkeypox activity. So right now that currently means that men who have sex with men have a little bit of a higher risk at this time epidemiologically because we have seen some outbreak within that population, though that again is a moving target because as it can spread to other social networks, you may see other populations being considered at higher risk. And the last factor is contact with dead or live wild animals or exotic pets that are African endemic species or using products derived from such animals. So that one's a little bit wilder of a criteria, but if someone comes to you with that sort of history, certainly that would present as a risk factor. Some exclusion criteria. So if you can find an alternative diagnosis that really fully explains the illness, then that can lead you away from this testing algorithm. And if they don't develop a rash within 5 days of their illness onset, that also functionally rules them out as monkeypox.
That's a lot of really good information, Lauren. Thank you. And again, if any questions come up, please feel free to raise your hand or put them right in the chat. Lauren or Rebecca or Kate, do we know if we have any epidemiologic data about the cases that have been in the region? Have those been in any particular social networks?
I don't know, Rebecca, if you're, I'm not aware of that, Munish. I will just add one piece from an interesting ID blog talking about this, but just saying that we probably part of why we're seeing more cases in the men who have sex with men category may be related to a lower threshold for seeking preventative health care related to sexually transmitted infections. So just kind of a thought to, so basically don't think that if someone is not in that population that they would not be, that they would necessarily be at lower risk. So I think that's just an important addendum that we are seeing that data-wise nationally, but that may be actually just more of a presentation and a bias than anything else.
Great. Lauren, you very nicely laid out the criteria. If you have someone who you see that you're concerned about, what's the process? How do we test, or who do we consult? If you can walk us through that, please.
Yeah, now it can be a little complicated, and my disclaimer to this is that there's going to be quite a bit of variability amongst our different sites for a variety of reasons. One being that it's very jurisdictional based on your Department of Health. So Maryland criteria and DC criteria on testing and swabbing and collection, all of that is a little bit different. And I'll talk about some of those differences. And of course, your availability of consultants is also different. So some have access readily available to ID, being very hands-on in your department. Others don't really have that resource, so that may change a little bit of your process. So if you have questions about your process, I encourage you to contact your local ED leadership for guidance, because they can provide some of the specifics that I won't be as familiar with, or that are a little bit too tedious to get into on this pop-up. I do think it is safe to say that most sites should be notifying their infection prevention on call when they have a potential case, and that's useful. They can assist you with infection prevention guidance. They'll help with tracking the patient, particularly if the patient is admitted to your facility, and they can provide the needed forms and swabs, so that's useful. At Hospital Center, we also ask our team to notify our ED admin on call when we have a case. That helps us with tracking and for waste management down the line, and that can just be an email so that we have that heads up. And our nurses contact our nursing supervisor in real time as well, so that they're aware that we have a case. That also may change as things evolve, as if there were an increase in case volume, the list of who you call may change, but that's currently where we stand. So those are the first calls. Then there's, of course, calling infectious disease if they're available to you. And they can be really helpful in this process. They'll help you determine whether or not to proceed with testing. They can help you consider alternative diagnoses for the patients. They have been recommending also that we send a full respiratory viral panel on patients that we're considering this diagnosis. That's been helpful. And for us at Hospital Center, they also liaison with DC Health, which is a huge help. So they make the phone calls, they're filling out the paperwork. When they're in-house, they're even doing the sample collection for us. And so that makes it a very streamlined process for our team. But of course, that's going to be variable for where you work. So ID is usually the first call. Talk to them. They are your lifeline in this process, and they're very familiar with the workflow for this. And then, of course, there's contacting your local Department of Health. So the bottom line is the Department of Health is the true determiner on whether or not we proceed with the testing. So they're the gatekeeper. We can think that we need testing, but they'll be the ones who really determine that. So having a low threshold to engage them is helpful, and call early in the process. So there's, of course, different jurisdictions. So DC has their own lines of who you call, and Maryland as well. And again, at Hospital Center, we're not making that call. That's done by ID. But I know at multiple sites, it's the ED doc that's making that call and arranging that. Also, before you swab your patient, I recommend getting an accurate phone number for the patient so you have good follow-up. That's really, really critical for getting the results because most of these patients are well enough to go home. So we need a way to contact them and for the Department of Health to contact them. Make sure it's written in the chart and take pictures of the rash and upload them using the MedConnect Capture app. That's super helpful for everyone involved to have those in the medical record. Okay, so swab collection. Again, this is variable between DC and Maryland. They have different criteria. And so at Hospital Center, we recommend that a clinician does the swabbing. So as I mentioned, ID will actually do the swab sample collection when they're in-house, but our docs will cover that process and PAs cover that process on the overnight or off hours time period. We also sometimes will engage dermatology if infectious disease wants them involved in the case as well. They'll do biopsies and they can do a little bit more tissue collection. So that is an option depending on your resources. So the swabs are a little bit complicated. So in DC, they want to use dry swabs and each lesion needs to be swabbed twice and a minimum of 2 lesions get swabbed. So that means each patient has 4 swabs minimum. More is bonus in their mind. Now, why do they need all these swabs? So it's 2 per site because the first swab is run by the Department of Health for orthopox. And if it's positive, they send the second swab to the CDC for confirmatory testing. So that's why they need the 2 swabs. So it's a little bit different for the Maryland process. I'll get to that in a minute, but just to continue on with the swabbing process. So before you go in the room, I would recommend pre-labeling your tubes on where you plan on actually swabbing. So usually you'll have seen the patient, done your initial encounter, and then this is your second time going in the room. So you have kind of an idea of where the rash is. So you want to do like right forearm, sample 1, right forearm, sample 2, and like label them out so they're all set so that you don't have to take all of your samples in your PPE, shuffle them around into tubes and label them outside of the room. It's just better to have it kind of set before you go on. And then you want to vigorously rub the dry swab on the skin lesion, preferably on an open vesicle. The juicier, the better, which is a little nasty. The Department of Health, they will recommend that you try to unroof a lesion to get a little bit more juice out of it. Our ID group has, they say simple is better. I think if you do just a good vigorous rub, you're going to get enough. The last thing you want to do is be wielding a scalpel and kind of making a mess on a lesion trying to get a good sample. Just the lesions will have enough viral sample on them that if you get a good rub on there, it should be sufficient. So each swab gets its own tube. Each tube gets placed in its own lab specimen collection bag, and then you want to hand deliver them to their next destination. Where at hospital center, it's the micro lab, and you should coordinate with your site on where those go. In particular, it's important that they're refrigerated within an hour of sample collection, and to get to the Department of Health, it's usually arranged that there's a courier. So for us, our lab really coordinates all of that process. But again, that could vary at your site, but it needs to be a refrigerated sample and then couriered over to the Department of Health. And then we'll talk in a minute about the forms that need to be filled out. But to talk a little on Maryland's process on how it differs. So they want a little bit more data. So they want essentially 3 swabs per lesion. So they need the same swabs that DC requires, which is 2 dry swabs per lesion, one that they're going to run their test, and then the second that's confirmatory to CDC. But then they want a 3rd swab that's in viral transport media, because if the patient tests negative for orthopox at Maryland's Department of Health, they would like to be able to run the sample on for a variety of other viral panels. So they need one that's in viral transport media to do that. So that's 3 swabs per lesion, and they also prefer multiple lesions. So you're talking about 6 swabs per patient minimum for collection. The process is also the same, where they'll recommend trying to unroof the vesicle if you can. If you collect any tissue, so a scab, a little crust, something like that, that's great. They want that. You put it in a dry tube. So no viral medium for that. And that applies to both DC and Maryland. For the forms, so it feels a little bit like applying to college to get a sample over to Department of Health. So essentially, DC has 2 of their own forms. One is the DC Department of Forensic Sciences General Laboratory Services Request Form, and then they also have a General Lab External Chain of Custody form, and then they request that we fill out the CDC Specimen Submission form as well. Maryland Department of Health, they just have, that I'm aware of, one form, which is their febrile rash form. I'm not sure if they require the CDC form to be filled out by your team, or whether that's done on the back end. But that's a separate packet of forms that probably your department will provide for you in some capacity, so that you can fill that out in real time, or the person who is responsible for that will do that. Again, for us, that's ID 24/7. If it's in the middle of the night, they will do that process in the morning to fill out the forms and submit the sample. So it's stored overnight in our micro lab. So bottom line, ask for help, call early, talk to ID, talk to infection prevention. They're there to help you. This process is a little bit complicated. It's a lot of sample collection. So, phone a friend is my recommendation on that process. Because again, it is a moving target. I do anticipate things may change as things evolve, as they always do in these kinds of outbreaks.
Yeah, really, really great information. And so, some of the things that I wrote down here were, it sounds like maybe five phone calls: ID, IP, ED leadership, nursing supervisor, Department of Health. You may not be making all of those, but all 5 of those calls sounds like need to happen. And I want to take a step back. Kate mentioned some of the isolation procedures, and just kind of thinking through the people that come through the emergency department. And, we're going to have varying degrees of concern when one presents. At what point would you isolate someone? Like, I think we had 130 people in the department most days that I've worked this last week, with 40 treatment spaces. Are we saying that people need to be in private rooms? Are we saying that like at what point, and then to what degree are we isolating folks?
Well, Munish, that is always a tough question. The ideal is febrile rash, particularly a rash that is vesicular and looks suspicious, should come back to a room. And ideally, that should not be a room with other non-PUIs in it. that is what we would love to try to do. And look, here's when I was working last week, you know, and if you guys can imagine, I did in my huddle say, you know, febrile rashes, let's PPE and think about monkeypox. And so we got called to look at a lady who clearly had cellulitis. I mean, like straight up, this was clearly cellulitis. And so like I could look at that and say like, okay, this is fine. Like, you know, we're not going to worry about it. So I think there's some clinical judgment in there, Munish, and it is tough because, you know, and Rebecca, jump in and you know, you do, you know, the realities of our environment, and, you know, there's not an exact answer to this. This is an art rather than science question in my view. But Rebecca, what are some of your thoughts?
I agree with what you're saying, that, you know, it's not a perfect world where we can put everybody on isolation immediately as soon as they come into the ED. But I think that as soon as the concern for monkeypox crosses your mind as the clinician taking care of the patient, that they should be put in a room for isolation.
And I think a important piece to that is just early screening, right? Like this screening should be happening up in triage when the patient hits the door. What the worst thing would be having a patient sitting in the waiting room for 8 hours waiting to be seen because they have a low acuity rash and, you know, they're not being isolated at that time. So early identification is really key, making sure your triage teams are aware that there's this outbreak and what to look for, I think is helpful.
And also making sure that they keep their lesions covered as well. So like if they're wearing a long sleeve shirt, that they're having it like rolled down and not rolled up. So like small, like little adjustments like that can make a difference too.
Mm-hmm. Masking the patients. And it's just another reason to keep those patients masked. Drawing the curtains, closing the doors.
Now, I think another interesting piece on isolation is home isolation guidance, which we don't really have an easy discharge instruction on that, but the CDC, if you go to their website, does have some home isolation recommendations for patients. So I would recommend printing those out if you have a patient you're sending home. But also, you want to stress the importance to avoid contact with their pets, especially rodents. We're really trying to avoid spread of monkeypox to become endemic into the U.S. pet population. So that's a critical piece of advice for patients.
Okay, yeah, that's a great pearl. And again, that would be on the CDC website for instructions for quarantining. Is that right? Okay.
And I think that urgent care may be working on a discharge instruction, you know, into MedConnect. So we may see that coming in the coming weeks. But yeah, there's a nice page on the CDC site, and it's a lot of the same isolation instructions we give for COVID. So again, we're familiar with don't share bathrooms, don't share, you know, all those same things we've been telling patients for 2.5 years.
Great. Rebecca, I'm wondering if you can talk a little bit about treatment as well as the role for vaccination, and maybe three parts to that, of the patient, and then if there's a role for vaccination of the clinicians.
Yeah, that's a great question. So in terms of treatment, most people are going to recover from this without any issues. So we actually just recommend just sort of clinical support and not giving any sort of antivirals or anything else like that. In terms of people who would sort of qualify for some sort of antiviral treatment, those are really our immunocompromised patients. And then people who have like pretty severe disease, so anything that involves the eye, the inside of the mouth, etc. And these are the patients who we would then need to communicate with the CDC with in order to get a medication called tecovirimat. And this is an antiviral medication that was approved for use in smallpox, but they've sort of extended the use via like compassionate use protocols to allow us to give it to patients who are having or who are infected with monkeypox who may need additional treatment. There are like, you know, there's options with like cidofovir and brincidofovir, but I think that tecovirimat is probably the better of the options for us to use. Then there's also Vaccina immune globulin, which is also sometimes listed as a possible therapeutic option. But in reality, we don't have any data with using this for treatment of monkeypox, but it is something that could be considered, especially for somebody who has like a significant T-cell immunity dysfunction or something along those lines where, you know, if they had an exposure, you could use it almost as like a post-exposure prophylaxis. Which kind of then transitions into the vaccine and who should get the vaccine. So in terms of people who should get the vaccine, really the CDC kind of like outlines for us that it's really people who work in labs that are handling the specimens. And then the other group was people who are administering the vaccines themselves. So those are kind of the two big groups that they say should definitely be vaccinated against, who should receive one of the two smallpox vaccines that are available. Those are the Jynneos vaccine, and there's another one, the one that we all are more familiar with is the AKM 2000 vaccine. Both of them are live. But the Jynneos is a little bit more attenuated, and you can actually give it in our immunocompromised patient population. And they're both approved for smallpox, but they have like extended use for monkeypox as well. In terms of administration, in terms of for like post-exposure prophylaxis, the CDC recommends giving the vaccine within before the 4th day of exposure. So if you're within that initial like day 0 to 4 and have a known exposure, that you get the vaccine in that period, because that's when it's going to be most effective. Outside of day 4, you can also receive the vaccine, but it's thought that it might not be as preventative, and it may just result in a less severe form of the illness. In terms of which healthcare providers should receive it, because of the fact that we're all sort of wearing masks anyways when we go into patients' rooms, like at least the surgical masks, and that we're all kind of on high alert looking for this, we haven't recommended it, as far as I'm aware, to any of our providers in the greater DC area who have seen a patient with monkeypox. So I think that that's something, getting the vaccine is something that will probably be done in conjunction with the CDC and our local health department, depending on how big of an exposure somebody had.
And Munish, I'll just piggyback on what Rebecca's saying, because right now, certainly in DC, all of the vaccine is held by the DOH. So I just want everyone to understand that those are not decisions that we can make at the MedStar level right now. Those decisions about post-exposure prophylaxis are only being made at the DOH level. I know the DOH has talked about some post-exposure prophylaxis of family members of the cases, but agree absolutely with Dr. Kumar that we're using, again, PPE during our care is going to protect us from needing that right now. So, but the number of doses right now is pretty small that they have, and they're making all those decisions.
And that's both in DC and in Maryland?
I know for sure in DC, and I believe in Maryland as well. I would have to confirm.
And sorry, I think maybe, was there a comment there? Did I cut somebody off?
Oh, I was just going to say, and the vaccines are pretty not pleasant to receive as well. And so if we can avoid giving it, I would say that's like the best thing to do is, like, I guess a good offense is a good defense, or some other sports metaphor like that, you know. So ideally, we wouldn't have to give the vaccine to people, and just sort of reiterating what Dr. Kellogg was saying, that we just all need to be cautious and wear PPE.
Okay, great. I think we've covered all of the key points we were hoping to discuss today. Kate, Rebecca, Lauren, anything else that you can think of that would be helpful? And as you're thinking about that, are there key resources? CDC was mentioned already. Are there other key resources that would be great for our clinicians to bookmark?
Honestly, the CDC website has evolved a lot over the past month or so since this became an issue within the US. So I actually think that it's a really great resource, and it has a lot of great information. And it's also a lot more up to date than, say, our infectious disease textbook that we all refer to.
Makes sense.
We also we have a couple resources that we keep at our charge nurse desk at Hospital Center. So there's a few printouts and packets of the testing kits along with additional information and instructions for clinicians to use when in real time. So that's a reference at Hospital Center, and I would recommend that for every site to have basically a go-to spot where you have some resources and where you keep your test kits so that people can step-by-step remember how to do this process.
And I know certainly ID is a resource at most of our places, but certainly IP at all of your entities is your go-to resource. Our IPs are in close collaboration with all of our ID leaders and then our team, and so they know how to help guide you, and they're there for you. So please feel free to use them too.
Great, and we have a question. Dr. Murray, go ahead.
Yeah, hi, this was excellent, very helpful. I have two questions as it relates to people who have previously been vaccinated for smallpox. I'm thinking of like members of the military. So my two questions are, how effective is that vaccine? And what is the duration of protection from when they received it? So if like it's been a couple years and they come with a rash, like how concerned should I be that it is monkeypox?
And Dr. Kumar, you're muted. Yeah.
The CDC advises that if it's within the past 3 years that you should have some protection against monkeypox. Anybody who's been vaccinated like 4 years ago or something, you may still have some immunity, but it's not as sure of a thing, I guess, compared to the people who've gotten it within the past 3 years.
Thank you.
Great. Any other questions? We heard a lot of great information from what monkeypox is, how it's transmitted, how we should be handling patients who with concerns when they come in. One of the key messages I heard was evaluate early in the process, ideally in triage, so you can develop your own pretest probability, your own level of concern, so you know kind of how much resource to consume in terms of isolation early. Call early, call often. There's a number of phone calls that need to be made. If the swabs are going to happen, there's a number of swabs. Sounds like it's going to be very local to whether or not it's DC or Maryland, and then in your individual hospital. And then treatment, our ID colleagues are going to help navigate that process. And DOH really is going to help with the role for vaccination and post-exposure prophylaxis. Great. I don't see any other questions. I really want to thank all three of you, Dr. Kumar, Dr. Kellogg, Dr. Wiesner. It was really outstanding.